Fecal incontinence, involuntary leakage of feces through the anal canal, anus is fecal incontinence. Urinary urgency incontinence plus stress urinary incontinence is called as mixed urinary incontinence. Urinary incontinence plus fecal incontinence is called as dual incontinence or double incontinence. So, in our daily routine, daily OBGYN practice, we encounter less cases of fecal incontinence. Most common reason what we encounter is perineal tear, from ranging from 3A, B, C, 4 degree according to Sultan classification. And even if you have noticed, that patient even does not present as fecal incontinence in very early, after many months or years usually they present, and when they have especially the episodes of diarrhea, then they are bothered more. The ticket gets used, adapted to it, fecal incontinence. So why we are dealing, many of you might not correlate to this topic today. Why is the fecal incontinence so common or so important to know it? But if you are dealing with urinary incontinence, if you are dealing in your clinical practice with patients with having urinary incontinence, then fecal incontinence, knowledge of fecal incontinence is very, very important. What happens is, urine urogynecology is all about history, a very good history, and a good history. Urinary patient complaints have associated majority of fecal. Isolated fecal incontinence is less common, only with obvious cases of perineal tear for that structural defect present with perineal fecal incontinence. But majority of fecal incontinence occur in the dual or double incontinence, urinary incontinence and the fecal incontinence. In urogyne, you have to ask patient the leading questions to get the history. So whenever you come across with a patient with urinary incontinence, do inquire for fecal incontinence. So here today we are going to discuss about the fecal incontinence. So, dual incontinence is more common. Fecal incontinence. What are the causes? Now, one is the structural causes and other is the functional causes. Structural, most common known to us as a OBGYN is perineal tears ranging from 3A, B, C or 4 according to the Sultan classification. The perineal tears, rectal prolapse, rectocele, anovaginal fistula, previous history operative for hemorrhoids may have present as fecal incontinence. So these are basically the structural defects which lead to the fecal incontinence. Then there are the functional causes, which are a long list of the functional causes of fecal incontinence. They are IBD, inflammatory bowel disease, chronic use of laxative, advanced age, menopause itself is an independent risk factor for fecal incontinence. Patient who had delivered by cesarean section, yes. Patient who has delivered vaginally delivery, they may also have the fecal incontinence. Depression, patient on depression, parasitic infestation, skin tags, large enlarged skin tag, poor hygiene, hemorrhoids. This all may present with the fecal incontinence. And again, in this here comes the pudendal neuropathy, neurogenic injury. Patient is a pregnant, she may have a cesarean section, but because of the neuropathy, the patient may have fecal incontinence. Neuropathic may also lead in vaginal deliveries. Okay, there are again other causes apart from deliveries which lead to pudendal neuropathy, but more common in our setup is the OBGYN, that's the deliveries. Pregnancy itself is a cause for risk factor for pudendal neuropathy, which may lead to fecal incontinence. Okay, so these are the various causes of fecal incontinence which we see. Now there are subset of patients. One is a structural defect. We'll go with the most common cause like perineal tear. When the structural say you see perineal body is absent, normal is 2.5 centimeter. So perineal body is absent and the patient is having the incontinence. Now there are patients with the perineal body is intact. You can see the perineal body 2.5 centimeter, but the patient may present with fecal incontinence. In that cases, it might be the functional causes which we have described. So many a list. I might have missed even one or two, because they have a very long list of the causes of functional fecal incontinence. So there is a subset of patient where the perineal body is intact. The causes may be the functional causes which has been described for fecal incontinence. Then again, there may be occult perineal tears, occult sphincteric injury, which is not visual intact. We can't see on the clinical examination. Perineal body is intact, but there are occult tears which are not been healed or not been repaired, and it may lead to fecal incontinence. It can be complete structural, it can be functional, or it can be both. structural and functional defect with the intact perineal body, which is fecal incontinence, which is the most difficult to treat, or in fact most difficult. It's underdiagnosed because it's not detected. That's why the fecal incontinence, it's a you patient comes with urinary complaint. They are embarrassed about the urinary complaints. We are not still, and there is a stigma. Urinary complaints, patients still feel a stigma to present to the doctors to this. Fecal incontinence, again, it's more embarrassing for the patient to tell that she is having fecal incontinence. Usually, the episodes of defecation is once per day, and it's early in the morning, and the females get up more early, so they don't usually they're easily accessible to the bathroom, so they don't get their quality of life is not affected with it. And if it's, then still they compromise because it's only once urinary problem, still the patient report earlier with the urinary complaint than the fecal incontinence. So it's basically prevalent, but it is underdiagnosed, and results of treatment also not as effective as for the urinary complaint. So this is it. So when we proceed further, we'll see somewhat the basic anatomy. So what it is, rectum, and then it is 3-4 centimeter of the anal canal. So what happens is the rectum holds around, when it's hold about 250 to 3 ml of the content, it's gradually getting distended, but when it's hold to 250 to 3 ml of the content, then the sensation goes from here by the parasympathetic nerve, and it induces the relaxation of RAIR, recto-anal inhibitory reflex, the most important terminology in relation to the fecal incontinence. When the rectal distension occurs to 300 ml of volume approximately, the parasympathetic nerve sensation induces the relaxation of recto-anal inhibitory reflex, which is normally present to maintain the continence. So it inhibited the content comes to the anal canal, it senses, then it senses whether it's liquid, solid, or gas, whether it's the right time and place, and then it gives the signal to the brain, and that's according to how the body acts. Okay, so this is the main how the mechanism, one of the mechanism how the function exact the defecation process occurs. Now, we have seen the causes, we have seen why it is important to know fecal incontinence, because it usually occurs with urinary incontinence. Now, how to ask, how to evaluate urinary incontinence? How you evaluate? You ask the patient whether there is a sudden urge to which is difficult to defer, that is urgency. SUI, any leakage of urine during the raised intra-abdominal pressures like coughing, laughing, sneezing. So it's very simple. Two examples we are taking: urgency and SUI, urinary. Fecal incontinence is not that simple to ask. How you will evaluate? There are few steps. Very first thing you ask the patient is history of constipation. Constipation is a root problem of all the urogynecological problems. Patient have urgency, patient may have constipation, patient have recurrent UTI, patient may have constipation, patient may have prolapse, but she is more bothered with the constipation. The constipation has to be addressed in all patients of urogynecology. Again, constipation is more difficult to treat. Many patients may not aware that actually they are having constipation. For this comes the next question. First, you ask the patient the constipation. Patient may say yes or no. If she's having, she may say yes. If she's not having, she may say no. But now the next question you ask: how many episodes of defecation she go per day? Patient may go 2 to 3 to 4. For them, it may be normal, but the patient may be defecating small amounts with straining, with the hard stools. So this is not normal. So according to the patient, she is not constipated. But when you ask the second question, the number of defecation per day, then you come to know actually she is constipated. Okay. So once you ask the constipation, you know also see the what the type of constipation, you see how many episodes here. Then you ask whether it's the passage of the consistency of the stool, whether it's hard, it's loose, it's soft. There is a need of any of the straining for the stool for defecation, where there is any need of the patient may go only once a day with no passage of hard stool, but she daily strains to her. So obviously there is a chances to develop pelvic floor dyssynergia, prolapse, nerve damage because of chronic straining. So okay, so you need to ask this: constipation, number of defecation, consistency of the stool, and need to strain. Minimum this 4 points need to ask for any patient we are suspecting or asking related to fecal incontinence. For that matter, any urogynecological patient, even with urinary incontinence, you ask this 4 complaints. Then comes specific to incontinence, how the patient may present or how you may ask, need fecal urgency when there is a desire to defecate, whether she is cold. Now in feces, just don't ask for 5 times. You specifically ask when there is urge to defecate, whether she is able to hold the defecation for minimum 15 to 20 minutes. Because it's solid, so usually 1 to 2 minutes or 5 minutes, normally any patient with incontinence may also be able to hold. Depend grade, some patient not even hold it that much, but you ask minimum for 15 to 20 minutes whether they are able to hold. Then comes this fecal sense of fecal urgency to the patient when there is need for defecation, but is not associated with leakage, may or may not associated with fecal soiling. Then again, one more step, what we ask is the complaint of passive fecal leakage. Patient is not aware the soiling of clothes is happening. Patient may go to urination for in the whole day, and she may notice that there is somewhat fecal soiling to the bed, where she is not aware. That is passive fecal incontinence, and it is usually indicative of damage to the internal anal sphincter, which is most difficult to treat. Okay, and even there may be complaint of flatus incontinence. Patient may be stool solid, may be continent, liquid may be also she may continent, but there is incontinence of flatus incontinence. Okay, so these are the now normally patient may not really be affected with it. So always in urogynecology you go for the questionnaire to see how what is by which symptoms she is affected, what the quality of life how it's affected. So there are various scores for this. One is Wexner and commonly uses Cleveland Clinic Incontinence Fecal Incontinence Score, CCIS, and Wexner. There are many other, but any of them you can use. The questionnaire is very important always, as in all urogynecology cases, as I always say. So this is the constipation, number of defecation you asked, training, consistency of stool, fecal urgency associated with leakage, not associated with leakage, passive fecal incontinence, flatus incontinence. This is the minimum 7 questions you need to address each patient of fecal incontinence. Then comes the examination. You have seen the causes, why it's important, somewhat mechanism, and what questions you need to derive, ask the history for the fecal incontinence. Now examination, inspection. You see for the rectal prolapse, you see for the rectocele, you see for any scar mark, you see for the excoriation of skin, any fecal soiling is there. This is the you see on the local examination. Then, as we see in all our previous videos, whenever you do any urogynecology, the prerequisite for urogynecological examination for prolapse, for incontinence, urinary fecal is neurological examination. At least you need to do anal wink reflex, a must you might need to do for before proceeding for the palpation or other further evaluation. So inspection, then you do the anal zinc reflex, then you proceed. Now specific limited to fecal incontinence, you do the PR examination. Obviously you see the if there is any tear, absence, presence of perineal body, presence, absence of fistula, then there is one betadine dye test, and there are many you see any scar mark, prolapse grading, perineal descent, descending perineum syndrome more than at least 3 centimeter, then it's significant. So these are the obvious things which you see, you obviously notice. Again, specific for the rectal examination in fecal incontinence, as again we have seen in previous one of the videos, levator anatone, how you assess. Levator anatone you assess in resting position and in the contraction when you ask the patient to squeeze. Same is the parectal you do. In parectal also you see the resting tone of the patient, resting tone of the anus. In parectal examination you see the resting tone. Now resting tone denotes the internal anal sphincter strength. 80% of the resting tone is derived from internal anal sphincter. So you assess the resting tone, so it gives you a rough function idea of the internal anal sphincter. Then comes the when you ask the patient to squeeze, then that is obviously the puborectalis muscle, external sphincter. It gives the brief of rough idea around its tone. PR examination. Investigations. Specific to, as we are discussing fecal, first you rule out all the causes, structural, and as per the cause you investigate, but very specific to fecal incontinence, what investigation you do is the very first investigation, most important fecal incontinence, the structural, that is by ultrasound, sonography you do, transperineal, translabial, introital, or the endoanal. So endoanal is the gold standard, 100% it detects the sphincter, but again it's cumbersome to use, it's painful, not readily available, costly, and you have a very good substitute, that is you can do a transperineal ultrasound, translabial ultrasound, or even you can do the introital ultrasound where you just keep the TVS probe on just the fortuate and you can see the sphincter. structure, from where it's intact, defect, from which o'clock to which clock, 10 o'clock to 2 o'clock, whatever extent of the repair, extent of the damage the sphincter is having, that you can detect on the introital ultrasound for fecal incontinence. This will help in all the structural defect you are suspecting of the fecal incontinence. You do the introital ultrasound. Even in the structure, when you see, obviously by your naked eyes you can see that it's complete perineal tear. Still many of them prefer to do the introital ultrasound before operating. Reason to see what is the extent, so you know. Many of them, even during operative, they do the scan to see, to pick up the defect, because the edges give away, they go deep laterally retracted. So even many of the surgeons do it intraoperatively ultrasound to detect the toned edges of the sphincter, or you can do a pre-operative to have an idea. So you can compare pre and post picture. So this is one of the introital. In structural defect, you do, again as I said, there are subset of patient where the perineal body is intact, but they having fecal incontinence. So there may be functional causes, there may be structural causes, or both. So in that cases also you need it. So in short, all patient of fecal incontinence, you do a scan to see the structural defect is there or not. Intestinal thickness, extent, and the anal mucosa, the star-shaped anal normal mucosa is present or not. So this is the introital ultrasound. Then comes the anal manometry. As in urinary, you do the UDS, urodynamic studies for the bladder pressure. The same is anal. In the same way, you do anal manometry to see the rectal anal pressures. Okay. Do it in all fecal incontinence? No. So in which cases? Majority of the cases. Yes. Fecal incontinence associated with usually urinary incontinence, multidisciplinary approach, usually complex. Patient who's having a chronic constipation, not responding to laxative, it's an indication for anal manometry. Then, in cases of dual prolapse, mandatory, must to be done anal manometry to be done in cases of dual prolapse. Uterine prolapse with rectal prolapse, before operating, you do an anal manometry. Then, in case of suppose there is a perineal tear and patient has already undergone colostomy previously, and you have repaired the tear, perineal tear, and then before the reversal of colostomy, anal manometry is must. So this two you usually do the anal manometry. Other cases where you do anal manometry, any chronic, complex, not responding to conservative treatments, not responding to biofeedback, where you suspect nerve damage, you see the volumes, what it detects, what anal manometry detects, same the resting pressures, it will tell squeeze pressure, it will tell rectal compliance, rectal capacity, balloon expulsion test, RAIR, rectal anal inhibitory reflex, present or absent. Even it will tell you the stages of pelvic floor dyssynergia. Yeah, there are 4 stages of pelvic floor dyssynergia. So you even that's why I said in the cases of chronic constipation who are not responding to laxatives, or the patient who are using chronic use of laxative, you do an anal manometry. So better you know the what are the results. Okay, so you do this anal manometry. Then one more investigation in fecal incontinence, the difficography. Again, some prefer this over anal manometry or other ways, or there are many other indications. Some may do, some may not prefer. The one indication which usually is done with the difficography is basically a contrast, dye is inserted and the patient is asked to defecate. So what you see, basically the indication which you do the difficography is pelvic floor dyssynergia. We are suspecting dyssynergia as a cause for the fecal incontinence, or in case of chronic constipation with levator ani syndrome. So patients with levator ani syndrome with pelvic floor dyssynergia, you usually prefer to go for difficography. So this was in very short and comprehensively we described about fecal incontinence. Thank you so much for watching this video. Thank you.